Hey, good afternoon. This works very well with a 5-year-old. I get my kids twice on any particular shape. Doesn't have to be a lesson. Okay. I'm Dr Shaman. I'm one of the pulmonary doctors. I'm going to be talking about hypoxemia. What's the relationship between the talk and these things? Nothing both. Okay, so just a couple of clarifications. I'm going to use hypoxemia and hypoxia interchangeably, although the word hypoxemia is specifically refers to low diffused oxygen in the blood, or low total oxygen content in the blood. But hypoxia and anoxia is poor delivery of oxygen to the tissue despite adequate perfusion. So you can imagine ischemic gut to be a hypoxic issue, local in the gut, but someone who has low oxygen saturation to have hypoxemia, okay, global, low oxygen content in the blood. And of course, I'm going to clarify, I'm going to be mainly talking about mechanisms rather than processes and diseases. So for example, I can have a right to left shunt in my heart that will result in hypoxemia or hypoxia. So shunt is the mechanism, an SV, a ventricular septal defect will be the process, and the disease will be cardiac, intracardiac. So these are the distinctions here. So I'm mainly going to be talking about mechanisms. And when I'm talking about mechanisms, I'm going to refer to the simplistic model of the lung, where there's one airway, one alveolus, and one blood vessel. Of course, in some circumstances, I'm going to expand on that, but the main concept is that you have airway disease, parenchyma, which is the boundary between the alveolus and the capillary, and then the pulmonary capillaries. So the objective is to understand the mechanism, see the word mechanism there, by which hypoxemia, I'm going to say hypoxemia or hypoxia, develops. Apply an algorithm, which I'm going to show you in a minute, and I would like you to try to get a mental picture of this algorithm to differentiate between the mechanisms of hypoxemia. And then to talk about a little bit about the mechanisms of hypoxemia that underlie different diseases. So for example, if you have someone with CHF, you might have parenchymal disease, but you might also have airway disease if there is enough venous perfusion that causes narrowing of the airway. Such the thing that's known as cardiac asthma. Okay, so this is a joke. This is actually a sign on the highway that says no oxygen next time. Okay. All right. So the lung is designed in a way that's optimal for transfer of oxygen. The membrane that separates air from blood is about 0.3 microns. Do you remember the size of the RBC? 6 microns. So this membrane is really, really small, and it's under a lot of pressure. It's very tough. This membrane spreads up to between 50 and 100 square meters. Your body surface area is about 2 meters. So this is a very big membrane that is very thin. And this actually helps oxygen and gases in general transfer between the alveolus and the capillary membrane. Fick's law says that the thickness of the membrane, which is somewhere around here, is inversely related to the exchange of gas. So that works very well. And the area directly relates to the transfer of gas. There's lots more in this picture, but this is the main issue. You're not going to have the gas exchange unless you have that very thin membrane. So anything that makes it double the thickness, from 0.3 going to 0.6, is going to halve the ability of your membrane to exchange some of the gases. The partial pressures of gases are also important in determining how much gas moves around this membrane, and also a diffusion coefficient. The diffusion coefficient of oxygen is not as good as it is for CO2. CO2 has a much better diffusion coefficient, so even if your membrane thickens, you're still going to be able to get rid of CO2, but you will not get oxygen back. The reason you have an oxygen concentration of P inhaled O2, so the inhaled gas oxygen concentration of about 150 millimeters of mercury in this space, and the reason you have only 100 in the capillary membrane is not only determined by the thickness of the membrane. Not only the thickness of the membrane. This drop of 50, a third of the oxygen is lost between the atmosphere in your alveolus and the blood in your lungs. It's because there's continuous removal of oxygen into the body and supply of new deoxygenated blood. So it's not just the thickness of the membrane, but the speed at which the blood is moving out of the alveolus, therefore oxygen is being consumed. So this drop is not just the membrane. There is also a very strong effect from the speed by which oxygen travels through the blood. I want you to remember this concept because it's very important in interstitial lung disease. And then after the blood goes to the tissue, oxygen content in the blood drops all the way down to in the microvessels and the mitochondria to around 20 and almost 10 by the time it reaches the mitochondria. And this is also very important because your blood, your hemoglobin is designed to drop oxygen, to dump oxygen in those farther areas of the body. And it's designed, your hemoglobin is designed, or it has properties that allow it to hold on to oxygen when it's near the atmosphere. Do you know what makes the hemoglobin drop oxygen in the peripheral tissue? There are 3 things in particular. Anybody?
pH, KBG, and
temperature. So increased temperature, increased hydrogen ion concentrations, and increased DPG. And this property is very important because if you have defects in NOPs, then you might deliver enough oxygen to the tissue, but you might not drop it off and leave it in the tissue. You just keep holding on to it and move away, which means mitochondria are going to go to anaerobic metabolism at that point. This is when lactate is generated. Okay. So a perfect lung will have the oxygen concentration stay steady from the point it meets the alveolus until it comes out of the lung. But in an infected lung, this drop in oxygen concentration is going to constitute the AA gradient. AA gradient. Because our lungs are not perfect, we have an AA gradient. talked about Fick's law. Remember, CO2 diffuses much better than oxygen, 20 times better than oxygen, so you probably will be dead before you have CO2 poisoning from hypoxia. But we still have COPDers who don't, who have enough oxygen and have high CO2. So we'll talk about that, right, in a minute. Okay. So this is the shape of the oxygen-hemoglobin dissociation curve. No, sorry, this looks like oxygen, but no. This is the concentration of oxygen in the capillary while it traverses the alveolar membrane. Runs right next to the alveolar membrane. Deoxygenated blood comes to the lung at around 40 millimeters of mercury, and then this is the whole distance of time a hemoglobin, an RBC spends in contact with the alveolar membrane at rest, oxygen, about 0.75 seconds. You don't need the whole distance. You have a lot of redundancy. You have about twice a redundancy from the time you need to spend in contact with the alveolar exchange membrane. You fill up your hemoglobin with oxygen within 0.25 seconds, and then you spend the whole rest of the time doing nothing. The hemoglobin molecule in an RBC gets in contact with the oxygen membrane, and then it fills up with oxygen in about only a quarter of a second, and then it spends half a second still in contact, but without holding on to more oxygen. Because when you exercise and you increase your cardiac output from 5 liters per minute to 15 liters per minute, you still need your RBCs to fill up with oxygen, although you increase the speed of blood flow in the circulation. So this is a normal lung. The hemoglobin is going to fill up very quickly. But in a disabled lung that has, let's say, interstitial lung disease, you might need to spend the whole time that you can in contact with the alveolar membrane to fully oxygenate the hemoglobin. So if you exercise, oxygen is going to drop, and it's not going to, the blood is not going to fully saturate with exercise. So if I ask you, I have two patients, I don't know which one of them has COPD and which one has ILD, interstitial lung disease. Which of the two will have a perfectly good saturation at rest, and as soon as they stand up and walk, they're going to have a precipitous drop in their saturation? And which of the two is going to have a reasonable saturation at rest, and then as they walk, they're going to have a drop in saturation, but not a precipitous drop in saturation? I'm talking about rest 98, exertion 82. Is it the COPD or the ILD person? ILD person. So the COPD doesn't have this problem. They have a different problem. Okay. New concept, and then we're going to tie all of these together, I think. Yeah. So I want you to think of our lungs when they are perfect to have perfect ventilation and perfect perfusion. So this is the alveolus, this is the bloodstream. You can ignore the numbers for now, but you have perfect ventilation, perfect perfusion. The ratio between the two is 1. That's perfect and perfect. You get 1. Normal lung has a VQ of 1. Normal alveolus has a VQ of 1. An alveolus that has no ventilation is blocked, 0 ventilation, and perfect perfusion is going to have a VQ of 0. And if you have a segment of the lung or an alveolus that has really good perfusion, a really good ventilation, but no perfusion, is going to have a VQ of, you can see this. If you can't, you can divide 0 by 1 and you'll get, 1 by 0 and you'll get infinity. So, how can you remember this really quickly? So I want you to think of someone who is sitting and dreaming. So someone sitting and dreaming. Shunt, sitting, S for sitting, and shunt is in the low, is a low VQ state. And dreaming, which is up here, dreaming, is a dead state. Can you remember that? Sitting and dreaming. And also, the lower parts of the lung, the bottom of the lung, the alveoli at the bottom of the lung, have more shunt than dead space. And alveoli near the top of the lung have more dead space than shunt. So if I see you in the hallway and for some reason I ask you, the top of your lung has more shunt or dead space, what are you going to say? You're going to ask me first, why are you asking me? When we're not on round, and then you say, and if I say to you, I have a lot of shunt in my lungs, you're going to think this is happening where? At the bottom of my lungs. And you will also know that my VQ in my areas of shunt is low, 0, or low. Low VQ is shunt, high VQ is dead space. Easy to remember? You have that image of me sitting and dreaming? So you're traumatized for life. Good. Okay. So, 28-year-old lady without the mental status, has history of seizure, non-compliance with AED. Recently went to Florida. She's a smoker on OCP. Perfect storm for FEE. Good. She comes in febrile, tachypnic, not hypotensive, hypoxic unaware, but she also has a respiratory rate of 4. Now remember, she has a history of seizure. Not pregnant, has benzos on board. Okay, so you want to figure out, does she really have hypoxia? Does she have hypoventilation? And what's the link between the two? What's the mechanism of hypoxia in this person? That's the question. So on room air, you have a gas that has a 732 50-50. This is CO2, this is O2. In this case, it doesn't matter, they're the same number. And how do you start working this out? So the algorithm goes like this. You start with CO2. Is CO2 high? Is 50 high? Yeah. So there is hypoventilation. And hypoventilation mechanisms are either respiratory drive or neuromuscular disease. And hypoventilation really is determined by CO2 production over CO2 elimination. So you can either have too much CO2 production, somebody is seizing, or you can have low CO2 elimination. So when I say that the mechanisms here are decreased respiratory drive and neuromuscular disease, this only addresses poor elimination, but it doesn't address increased production. So CO2 production over CO2 elimination. CO2 elimination is minute ventilation multiplied by 1 minus VZ over VT. What does that mean? You know minute ventilation. Everybody knows minute ventilation. It's vector rate times tidal volume. If I increase my rate or increase my tidal volume, I'm going to increase my minute ventilation. Therefore, I'm going to be able to wash out more CO2. But it also depends on this thing. DD, dead space ventilation. Now, in a normal person, dead space ventilation is only about a third, which is a lot, of your tidal volume. Every breath you take, you spend a third of your breath wasted. You waste breath, practically, every time you take a breath. But luckily, when we exercise, or when we hyperventilate, we don't increase our respiratory rate, we also increase our tidal volume. Therefore, we decrease the ratio of VV over VT because we increase our tidal volume. So respiratory rate times tidal volume multiplied by the negative, the subtraction of dead space ventilation from 1. And this is in the denominator. So, thinking about it for a minute, what happens to my CO2 if I have higher dead space? Goes up or down? Up. Thank you. So it makes sense, right? So people who have higher dead space are going to have higher CO2. If you decrease your minute ventilation, you're going to have higher CO2. If you increase your production, you're going to have higher CO2. And COPDers who are sitting in front of you, holding onto the back of the chair and doing this, and their CO2 is 55. What do they have? Increased minute ventilation? Do they have decreased minute ventilation, or do they have increased dead space ventilation? Dead space ventilation, because they're hyperventilating in front of you, but nevertheless they can't eliminate CO2 because their CO2 is determined by dead space ventilation. This is a normal lung, a little bit compressed from a sample punch, and this is a COPD. It's not that they can't ventilate, but they ventilate areas that don't contribute to gas exchange. So that's dead space ventilation. So you decided that this person has high dead space, probably doesn't have increased production because she's chilled, but she might. A little bit of fever can do that, can increase your CO2 production. But she definitely has low minute ventilation from low respiratory rate. Is there another reason for hypoventilation in this person, or is this it? Is it just hypoventilation, and we're going to ignore the PE issue or PE possibility, or is there something else? So this is determined by looking at the property of the membrane between the alveolus and the bloodstream. And to do this, you need to calculate the A gradient, which nobody wants to do right now, but you're still going to do it right now. Okay, so how is the A gradient determined? We said it's the difference between the amount of oxygen in the alveolus and the amount of oxygen in the blood. So A alveolar, A arterial, the difference. Easy. This is what goes into it. Barometric pressure determines part of or the majority of the alveolar O2, but also water vapor pressure determines how much oxygen you have in the alveolus, because a very humid environment is going to have less oxygen, and less humid environment is going to have more oxygen. So I'm going to propose that hospitals are made really, really dry in air. The air in the hospital is really, really dry, so that we have a little more oxygen by decreasing water vapor pressure in the environment. You okay with that? Show of hands. Who likes this idea? Who doesn't like that idea? Nobody cares. Okay. So why is this idea wrong? Because engineering experts say if you dry up the environment, it's going to survive longer than if you keep it humid. That's not it. Because air in the alveolus is fully humidified. Everybody's air in your alveolus is fully humidified. It doesn't matter if the relative humidity outside is 100% or if it's 0%. By the time air gets to your alveolus, it's fully humidified, so it doesn't matter unless your body temperature changes. Hypothermic people have less water vapor in their alveolus, but febrile people have more water vapor. However, our survival range of temperature doesn't make that an important number. But you have to remember that this plays a part in it. Nitrogen matters, CO2 doesn't matter. CO2 in the environment is a very small amount, but remember, CO2 diffuses 20 times better than oxygen. So you're going to have the alveolus really full of CO2 very quickly. And that, in a way, if you want to think of it as CO2 pushing oxygen out, is going to decrease the amount of oxygen in the alveolus. And FiO2, of course, determines the amount of nitrogen, which determines the amount of oxygen in the alveolus. There is an F, a correction factor, that you don't have to worry about right now. That's a small amount. It really depends on how much FiO2 you're inhaling. If you're inhaling room air, it's not an important number. It's like a 4% change. If you're inhaling 100% oxygen, it could be an important number because it can go up to 20%. So the measures PaO2, which is easy to get from an ABG, but the calculated alveolar O2, the difference between the two makes a gradient. You have barometric pressure minus water vapor pressure times FiO2 minus F, which we said we don't care about much, and then minus PaCO2 divided by R. What's R? Respiratory quotient. R is what you eat. Yeah. And it's almost always 0.8 unless you have a very specific diet need or you're on just unusual diet, like someone in the ICU who's only on D5 normal things. This is someone who's only getting sugar, not protein, no fat. Or someone in the ICU who's sedated on propofol who's getting only fat. That's the respiratory quotient of 0.7. So that's different. But normal healthy people who come in, or even sick people who come in from the outside environment, and you set their ABG, you're going to have an R of 0.8. But remember, sometimes it's not 0.8. Okay, barometric pressure in Cleveland is about 747, which makes it really nice because water vapor pressure at normal body temperature is 47. So 747 minus 47 is 700 times FiO2 of 21 is 147. So you're lucky training in an environment that has a barometric pressure that is 500 feet above sea level. Because if you were in Denver, you'd have to do much more complicated calculations. And you're in Mount Everest, they're just confused. There's no training program there. Okay. All right. So F exists because R is dependent on FiO2. This is the equation. I suggest you don't memorize it. Just saying, if somebody's on 100% oxygen, they have a little bit more. They have more problems than just their A gradient. Okay, the A gradient, therefore, is easy. 747 minus 47 times 21 is 147 minus 50 divided by 0.8 gives you 87. Is this a normal A gradient for this lady? Who came in with all of the risk factors for PE and has hypoventilation? Is it normal? Who likes this number? Who wants 87 as their A grade? Nobody. Okay, good. All right, so, but that's only her AO. That's only her alveolar O2. You subtract from this alveolar O2, which we calculated, you subtract the amount of oxygen that's in her blood, which is 50, and you get 37. So, is there a way to predict the A gradient for someone? Or what factors determine the A gradient? Age. Okay. I use age divided by 4 plus 4. Other people use age by other numbers. But whatever equation you use, just stick with it and try to apply it every time you look at somebody trying to figure out their A gradient. So this lady's A gradient should be 11. It's 37. There's something else. It's not just hypoventilation. So we said high CO2, hypoventilation. Is it all? Is the A gradient normal? Is it high, sorry? Yes, there is another mechanism. If it's no, then it's just hypoventilation. There's nothing else. So there is something else. Is this oxygen correctable with O2? What does correctable mean? So you say, okay, we have an ABG on room air. Let's get an ABG on 50% and see if it's correct. Our PaO2, does it increase with oxygen? Looks like it increases. But does it increase proportion to the amount of oxygen that you're giving? You double, you go from 21% to 50%, it's more than double. 1.5 the amount of oxygen. And the PaO2 goes up by a little bit. So that is not a good correction. A good correction is when the P to F ratio stays constant. The PaO2 divided by FiO2 stays constant. Does that mean anything to you? So this is what I'm talking about. If you double, if you go from 20 to 40 on the PaO2, I expect her, on the FiO2, I expect her PaO2 to go from 50 to 100. But she didn't. If your PaO2 is 100 on room air, on 20%, and I give you 100% oxygen, your PaO2 should become not this graph. I'm not going to continue until you tell me the right answer.
Can you repeat the question?
My PaO2 is 100 on room air. If you give me 100%, what happens to my PaO2? It should go 5 times. So the number is? Oh. All right, so this is what she did. That's not normal. This is normal. This is expected, not normal. It's expected. This is not. This is shunt. Her P to F ratio initially was 120. It's not 320. It actually dropped when you gave her oxygen, and that's shunt. So the mechanism is alveolar collapse, alveolar filling, pulmonary vascular disease, intracardiac shunt. Which one does she have? This is what she has. She has a shadow, silhouetting or making the right heart border a little hazy. On the lateral, you can see it somewhere here, and that's her implication. Okay, so why is it so difficult to increase oxygenation in someone who has a shunt? So I normally have a shunt of about 2 to 5%, depends if I have a big day or not. If you make me have a shunt of 50%, I will die. You can't save me with 50% shunt. Why is it so hard to oxygenate someone who has a shunt? Because of this curve, the oxygen-hemoglobin dissociation curve. You can't oxygenate someone more by giving them more oxygen. That's the problem. Saturation doesn't go higher if you give someone a lot more oxygen. And this is the problem. Because areas that are well perfused and well ventilated are already up here. And no matter what you do to the PaO2 or the oxygen that you deliver to someone, nothing will happen to their saturation. If I have a good alveolus, then I have good saturation. You can't make my saturation any better. But if I have a bad alveolus, then I'm not going to have good saturation no matter what you do anyway. And if you mix both blood, everything is going to drop from this area all the way to this area. And I'm going to have a saturation of around 50%. That's why shunt is bad. So, if you want to do numbers, this is what it looks like. Room air, and this is going to be 50%. So, you take someone on room air who has a shunt. This is their shunt. Okay? Full alveolus with good perfusion. Saturation is going to be 70%. And saturation in a good alveolus is going to be 92%, even if somebody has a disease. And this constitutes 75% of the alveoli. This constitutes only a quarter of the alveoli. The total saturation is going to be, if you calculate the oxygen content by using another equation, it's going to be about 87 on room air with a PaO2 of 50. If you give someone 50%, you're going to improve their saturation, but not as much as you increase the FiO2. You increase the FiO2 from room air to 50%, you only go up on the saturation by 8%, from 92 to 100. And the areas that are not perfused, not ventilated, nothing good will happen there. So the oxygen content is only going to go up a little bit, therefore saturation is not going to improve much. It's going to go up, but not as much as you hope for. PaO2 is going to all go up from 50 to 60, although you increase the FiO2. So the only way to do this is to put someone in a hyperbaric chamber and give them 3 atmospheres. Then you can improve their oxygenation, but nobody's going to be able to survive that easily. So, a different case. So that lady has an aspiration from benzos, and she didn't have a PE. All right. Because she had shunt. Shunt is not a PE. Shunt fills up the blood flow and not the alveoli. Does that make sense? You block the artery. You don't like that. Other way around? Oh, a PE, sorry. A PE blocks the artery and not it. Okay. 82-year-old person with COPD, presents with altered mental status, non-compliant, wheezy, smoker, recently hospitalized, fever, tachypnea, hypoxia. White count is high, hemoglobin is normal, and you get 2 blood gases because you're not going to waste time. You're just going to get 2 blood gases on 2 different levels of oxygen because you have the algorithm imprinted in your mind. I'm going to look at the CO2, and I'm going to say, oh, this person is hypoventilating. But is hypoventilation the only problem, or is there something else? So, you give them more oxygen than 4 liters, you go up to 60%, and the CO2 doubles. So, 4 liters, I don't know, you might have a certain idea in mind how to translate liters to percentages. I usually do 3% for every liter above room. So, let's see. Does this person have hypoventilation? Yes. Do they have high A gradient? Yes, because their A gradient, which we calculated already, is 86%. Does it correct with oxygen? You want to see the numbers again? So, if you use one of the formulas that it's going to turn out to be around 33%, and you go from 33 to 60, you practically double FiO2, you double PaO2. Does this person correct with oxygen? None. Yeah. Okay, very good. So, okay, PF goes from 212 to 233, it's really the same, and there is the mismatch. If you didn't correct with oxygen, what was the mechanism? You remember? It was alveolar filling, something filling up the alveoli, not affecting the vasculature. Big mismatch is caused by airways disease, interstitial disease, pulmonary vascular disease. It's the maculopapular rash of pulmonary disease. Big mismatch. You get the joke. Okay, good. All right. So what is leaky mismatch? You have an alveolus that has 1 ventilation, 1 perfusion, therefore the ratio is normal. You have someone who has ventilation of 1 but perfusion is 0. This is a PE person who has dead space. And this is a person who has shunt. And you see how dead space is high, shunt is low, right? High, low. So where is the mismatch? I don't see it. Anybody? I mean, I don't get it. There's shunt, there's dead space, there's normal. I don't have the mismatch. All right, so this is normal right here. VQ of 1. This is VQ of 0. This is VQ of infinity. VQ mismatch looks like this. It still is 1 overall, but you have more areas that are dead space, and you have more areas. More areas that are shunt, and more areas that are dead space. So we're all born with almost no VQ mismatch, and then as life goes on, we develop more and more VQ mismatch. People who smoke, or people who have chronic medical illnesses that damage the alveoli sometimes and damage the vasculature sometimes, they have more of these alveoli, and they have less of the perfect one. So their overall VQ is normal, but they have a mismatch, and that's what it looks like. There is no particular alveolus that has a VQ mismatch, but the overall distribution doesn't look normal. I saw this at the airport. Anybody tried that? Really colorful water bubbles and stuff. Okay. So I didn't try it. I didn't know if they were going to make me sign a release or not, because oxygen is as rod, and if you use it inappropriately, you're going to have more VQ mismatch. And someone with COPD, you might actually get in there and use oxygen, and if they give them more than 2 liters per minute, then they might actually develop hypercapnia on their way to the plane. So if you ever use it, send me a message. I want to know what the process is. So, 38-year-old man with dyspnea, no prior history, no vices, no man. New to the Denver area, love it. They were hiking on their break and had no fever, normal vitals, a little tachypnea with 88% on room. Normal lung exam. They're worried. They come to you and they're worried. They say, oh, I'm a second-year medical student. I heard about high-altitude pulmonary edema. I'm worried I might have high-altitude pulmonary edema. Why am I tachypneic? So what do? You listen to them. You get a blood gas? Yes. Yes, you listen to them first, then you get a blood gas. And the blood gas looks like this. So 736, 34, 70. So are they hypoventilating? No. Are they hyperventilating? Just 7. This should be 746. But I wanted to give them less tests, but that's not true. Okay, 746, 43, 70. So they are hyperventilating. Why are they hyperventilating? So there are three things that drive our ventilation. Brain, lung, and the chemistry of the blood. When I say brain, I'm not talking about the metabolic driver of breathing. I'm talking about the volitional driver of breathing. If you are sleeping and dreaming, and you're dreaming that you're being chased by a cat, and you don't like that, you wake up hyperventilating. Although there's no reason for you to be hyperventilating other than your volitional drive to breathe. So there are centers in the brain that determine the rhythm of breathing, and your cortex can take over those centers and just wipe them out and do whatever you want to do, such as me talking now. My driver for breathing, I just overrode it completely, and I'm just breathing as much as I need while I'm talking. So volitional central drive for breathing. Then there is the metabolic part. So acidosis is a very strong driver for breathing. If you are acidemic, you're gonna breathe. If you have hypercapnia, then you're gonna breathe. And if you have certain poisons in your blood, like aspirin, although without its acidosis, it will still make you breathe. Without causing acidosis, it will still make you breathe. And there are the lung parts. The lung part is when you get stretch receptors affected in the lung. So someone with CHF will hyperventilate because they have the stretch receptors affected and the J receptors and stretch receptors affected. So that actually signals to the brain that I need to hyperventilate. So if you have pneumonia, you'll hyperventilate. If you have a PE, although you might not be hypoxic, you will still hyperventilate. So if somebody is in a panic attack, they can't control themselves. What do you do to them? And they're washing out their CO2, they're ready to pass out. What do you do to them? Brown bag breathing, yeah. But to put a brown bag on somebody's head in the hospital doesn't look really good. You breathe in a, oh, not over. You breathe in a brown, okay, you breathe in a brown bag. Or you give them some medications to calm down their anxiety, which is overdriving their central drive, their metabolic drive. If somebody has a little bit of hypoxia, then they will hyperventilate because that actually stimulates the metabolic driver for breathing. This person is hyperventilating seemingly without any issues, with a PaO2 of 70, right? 70 is not normal. Normal is 90 to 100. So this person is really hypoxic. But why are they hypoxic? Why are they exhibiting the effects of hypoxia as hyperventilation? Anybody? Altitude. So, is it really pulmonary edema or is it just altitude? Is there a pathology in their lung or not? You need the A gradient. Calculate the A gradient. See? Is the A gradient high? That's the question. CO2 is normal. Is the A gradient high? And I hope I don't show the answer. Oh, okay. Yeah, calculate their A gradient. 747 minus 47 times rho is 147. minus CaO2 minus CO2 divided by 0.8, right? So this is what it looks like. And you find an alveolar O2 of 103, and their A gradient is 42. Yes? No. Why no? What? Okay, the barometric pressure. Yes, very good. So you change your numbers and you get this. Is this normal? For what was it? After 8, let's say 38. Probably okay. Yeah, their predicted actually is 14. So they have no increase in A gradient. It's only decrease in inspired O2. You can say to this person, you don't have pulmonary edema from high altitude. And they say, what about chest X-ray? And you say, no. They say, I'm going to sue you. And you say, you do it but reluctantly. You don't know. You're absolutely sure the normal A gradient that this is not parenchymal disease. There's no airway disease, no parenchymal disease, no problem in this person. So, high altitude pulmonary edema, no, because high altitude pulmonary edema causes shunt, which actually results in a high A gradient. Okay, so we talked about hypoventilation, shunt, leak, smash, and asphyxia, which is decreased inspired O2. This is the whole algorithm. I'll send it to the chiefs, and they can send it to you only if you ask for it. It's not going to go out automatically. So where is the fusion? I mean, I have hypoventilation, I have shunt, leak, smash, and O2. Where is the fusion block? Oh, it's right there. Interstitial, it's part of the mismatch. Whenever you're faced with a question about hypoxia and you don't know the answer for it, the answer is leak mismatch. All right. So the fusion block, like I said, is an ILD disease. For example, someone who's at rest versus someone who's running suffers from hypoxia, because you're not going to use, remember the graph at the start, you're not going to use all of your contact area to improve oxygenation unless you have the fusion block. This is a normal person. They will fully oxygenate within the first 0.25 seconds. The rest, they're just hanging out, doing nothing, the RBCs. And when you exercise, you increase the speed of blood flow. So you use all of the contact area, what you successfully oxygenate. But an ILD person is going to need most of the contact surface area. So when they exercise and they increase their cardiac output, they're not going to fully oxygenate their O2. Multiple mechanisms can be involved in a single disease. So, what's the mechanism of hypoxia in OSA, obesity hypoventilation, neuromuscular disease, myasthenia gravis, and Duchenne's muscular dystrophy? The same mechanism that affects all of these people, and it causes low PaO2. Can you yell it out? Hypoventilation, right? That's the major one. But there's another one too. Because these people all get epilepsy, and they get a little bit of sun. Usually at the top of the lung or the bottom of the lung? Sun. Bottom. Good. Okay. How about CHF, ARDS, Sprawley, transfusion-related acute lung injury, and high altitude pulmonary edema? What's the mechanism of hypoxia in these people? Shunt. And a little bit of diffusion block. So it's not just shunt. So some areas are still being ventilated, but at the same time they have diffusion block. And pneumonia, atelectasis, lung hemorrhage? Shunt, right? But sometimes these people wheeze. So they have these things. It's not going to be a pure mechanism in most of the situations. Airway disease have big mismatch, but they also have hypoventilation. Like we said, a COPD is going to breathe fast, so they can have very high density, so they have hypoventilation. And this just keeps going the same way. Diffusion block mostly in ILD, hypersensitivity in pneumonitis and sarcoidosis, and there's also big mismatch. Oh, I have more. Okay. Same issue. So here, I just want to remind you that PEs, patients with PE wheeze. Do you know why they wheeze? When platelets release serotonin, that causes bronchospasm. So don't be surprised if somebody with a PE has unilateral wheeze. That's going to be a very nice clinical exam finding. You can say it to someone and get them surprised. All right, here's another case. 51-year-old female with lower left upper quadrant pain, fever, and weakness, has normal saturation on room air, but has a bit of aberrant heart rate, white count 45, a lot of lymphocytes, a little bit of anemia. Rest of the numbers are good. Left upper quadrant is tender. X-ray looks, I don't see any infiltrate. You see them? Sure. And you get a blood gas. So blood gas on room air looks like this. On non-rebreather, 16 liters. Not 100%, but about 60%. You increase the PO2 from 42 to 44. What's going on with this person? PE? But the mechanism should be shown. So what's the next step? Which one? A, spiral CT for PE. So PCP, pneumocystis pneumonia, can be detected by gallium scan. That happens. Echo for bubble study if you're worried about shunt, because I said, hey, she must have shunt. Repeat ABG with sodium fluoride. Cold pulmonary. Cold pulmonary is the wrong answer on a test. All right. So what's the right answer? Anybody knows what sodium fluoride does? No. So would you choose it as an answer? You have other reasons, right? So it's sodium fluoride. What's happening with this person? She has, so the gray top is actually potassium oxalate and sodium fluoride. She has a very high lymphocyte blast count. Remember, she wasn't really hypoxic. The PaO2, the saturation was 98% on room air. I wonder why somebody drew the blood gas. But whoever drew the blood gas didn't put it on ice right away, or put it on ice, but she had such highly active metabolic white cells that those white cells just chewed up the oxygen very quickly. So if you draw the blood in sodium fluoride, you can kill the white cells right away, and then you'll have no oxygen consumption. So you can repeat that, but most people don't use sodium fluoride for their testing. They just send the sample. They put straight in ice, send it to the lab, tell them to run quickly, and that usually works. Another case: 62-year-old male with dyspnea, mucus, COPD history, comes in with fever, 88% on room air, tripod position, wheezing bilaterally, everything suggests COPD, and this is the X-ray. It's a little hyperinflated. Here's a flat head diaphragm on the left side, although there's a little bit of an angle, but you draw the blood gas, you get an A gradient of -33. What does that mean? So that means the amount of oxygen in their blood is higher than the amount of oxygen in their alveolus. How could that happen? Or that they are plants, okay, capable of photosynthesis, or there is a bubble in the sample. So air bubble is going to give you more oxygen than this. Okay. I don't remember who put this slide in. Lab handling. All right. So one more case. The usual cirrhosis, coronary artery disease, ex-smoker, heavy person with lower extremity edema, hepatitis, high BNP, low albumin, moderate perfusion, needs 6 liters. How do you work that? So, you have the potential of many disorders, but you're going to have, the first thing to do is that's X-ray, CAT scan, CTPE. If you remember anything from this lecture, it's a blood gas. Blood gas. The algorithm is a blood gas. You need a blood gas. Call us after the blood gas. Okay, very good. So we talked about the hypoxia mechanisms. The major mechanisms are hypoventilation, vacuum smash, shunt, and diffusion block, and asphyxia. So low inhaled FiO2, which is not very common. You have the algorithm in mind. You know what to start with, blood gas. And remember, there's a difference between mechanisms, processes, and diseases. You can have multiple mechanisms for the same process. You can have multiple processes in the same disease. Okay. That's it for today. Thank you.
Thank you. So, I printed this on, I